Vadodara. We are on Brain on Wednesdays, and the topic for the day is Mania and Hypomania, complete reanalysis based on cognitive neuroscience, neuroanatomy, connectonomics, and molecular genetics. And Dr. Bhaskar Mukherjee to put it across to all of us. Dr. Bhaskar, the platform is for you now.
Okay, so welcome all. This would be the last talk of the series, which was designated to give us some idea about how major psychosis develop. Next time onwards, there will be different topic and the speakers will be different. And this is just summation of all the things that we talked about in previous 6 sessions. This session would not be followed by a case discussion. We would be directly talking about some clarification of your questions, and then next session onwards, we would start with other topics in psychiatry. And next session onwards, it would not be me who would be hogging this session. The thing is, with this thing, let's start about mania and hypomania. I don't know how many of today's viewers have listened to the past 7 sessions. But if you have listened, then you already know that there is no separate pathophysiology for psychosis, positive symptom, psychosis, negative symptom, or mania or hypomania. That was actually our previous and past generation who had the observation and the phenomenology at their disposal, but they didn't have any real technological advances in their time, which could see the brain clearly and which could identify the different brain patterns. That has led to various phenomenological names that should be redundant today. But that is not because in psychiatry, we don't progress ourselves. We always go on repeating what was said before. For example, in every topic of this session, I actually have given the name of clozapine because I want people to think about clozapine and think how it has become the holy cow of psychosis. It cannot be questioned. People think that it is the ultimate drug for psychosis, which it is not. It is not a bad drug. It is neither a drug which has no usefulness. It has a lot of usefulness. It is the only part which has little or no extrapyramidal effect and It is a heavenly drug for any movement disorder and movement disorder associated psychosis. But the cult following that it gained was never questioned. Dr. Kane and his study of 1988 never replicated, never questioned. Even standing in 2024, we dare not question his criteria, his assumptions, and his observations, which were done in 1980. Because in psychiatry, we don't question anything. We make everything an axiom. We make everything a gospel. And that is what has happened to this psychosis, mania, and hypomania common problem. Here we also made our past generations observation a gospel. In brain, I have already talked about during positive symptom discussion that all the symptoms that are in positive symptom are actually symptoms of so-called mania and hypomania. There is nothing different between positive symptom and mania. But still, when a first year PG enters in psychiatry, we teach them there is a mania, there is a hypomania, there are divisions in mania and hypomania, and ultimately, thanks to Apiskal and his classification, we stamp every patient as some kind of bipolar, forgetting the natural history, forgetting everything. We need to come out of the fact. We need to face the truth that except first year PGs, nobody in this world of psychiatry has seen a patient who has bipolar disorder or who has schizophrenia. It is all the mixture. Anyone who has seen even 10 patients of psychiatry in their lifetime, they have seen the total full spectrum. And none of us can deny the spectrum. It starts with the pregnancy of mother, it goes on, and it ultimately develops in episodes, then the episodes becomes a continuum. And for some, it is continuum from the very first. Other than that, there is no difference. And that is why today I am not going to present any slides, because in my experience, when we present slide, no audience is interested in listening to the speaker. All they want is mugging up the slide. And this ultimate end session of this series needs a serious understanding from the audience side. I would want you to question your FZ assumptions. Everything that you have learned in your psychiatry PG and a post life. We have talked about B-SNP study when the introductory session was done by Dr. Nachiketa Mishra. I would talk more about B-SNP study. I would not show slides because B-SNP study is actually easy to No. I am sharing my screen and see in my screen there is a copilot, and for anyone who know what copilot is, or anyone who doesn't know copilot is
Just a minute,
Microsoft.
Dada. Just a minute. Your screen share is not coming through.
You are not seeing my
No, we are not seeing your slide.
Oh, you are not supposed to see my slide. You are supposed to see my screen. Are you seeing the screen?
Yeah, we are seeing the screen.
Yes, that is what I am trying to show, because no slide. Today, there is no slide. See, this is the copilot. This is Microsoft's ChatGPT and various other AI powered large language model AI. And I have just typed a question here. Show me a full image of bipolar and schizophrenia network of intermediate phenotype. That is the full name of Wisnip child. And see, even Copilot has given a summary. So I don't really need a slide for it. Copilot, or if you are interested in any other AI, Gemini AI for those who love Google, other AI, for example, those who are interested in trialing WhatsApp AI, the Meta AI, they can search in Meta AI. Bipolar and schizophrenia network for intermediate phenotype and sleeps is available in every large language model AI. It is a study which was done to prove that we can develop a differentiating criteria through which we can differentiate schizophrenia and bipolar. And anticlimatically, it proved there is no separate schizophrenia and separate bipolar. It was a trial done by a group of people who were opposing RDoC criteria by proving there are separate schizophrenia and bipolar. They have started the trial by recruiting a group of people who had bipolar psychosis or psychotic bipolar in DSM-4 at that time. Sorry, at the time it was DSM-5. DSM-5 and ICD-10 criteria, or schizophrenia or schizoaffective disorder. And then they mixed the group of patients, and then they applied a group of neurophysiological markers, a group of neurological marker, and a group of phenotypical marker to divide those patients into schizophrenia, psychotic bipolar, and schizoaffective disorder. Ultimately, to their dismay, they never got those patients. What they got instead, 3 groups. One group showing severe symptomatology, one group showing less than severe or moderate symptomatology, and one group showing mild symptomatology. And in severe, be it severe, be it moderate, be it mild, all 3 groups had so-called schizophrenia patients in it, so-called bipolar patient in it, and so-called schizoaffective patients. This group, which actually included many big names in American psychiatry, had serious shock over the results, and they tried to prove themselves wrong by following up these three groups. Although they initially published the data and they said that these are biotypes and things like that, they were expecting that ultimately these three groups would merge and some form of bipolar or schizophrenia or psychotic bipolar would emerge. But ultimately, after 5 years of observation, when the second stage of study is over and they collected data during immediate post-COVID period, they have found out that even these three so-called biotypes are not separate groups. They are just different phenotypical stage of a same biotype. One is the most severe form, biotype 2 is the mild form, moderate form, and biotype 3 is the mild form. And on longitudinal observation, patients shift from 3 to 2 to 1. So ultimately, in their effort to prove DSM and ICD true, they proved beyond doubt that there is no separate bipolar and schizophrenia ever. So, what is this mania and hypomania? These are just paroxysmal hyperactivity of autonomic system. Those of you who are interested in reading neurology literature and don't think that psychiatrists should not know neurology, they should go to a chapter in neurology. Paroxysmal sympathetic hyperactivity syndrome. This is a syndrome that happens when there is head injury, there is sudden immune disturbance in brain, or various other hyperexcitation state in brain. This paroxysmal sympathetic hyperactivity syndrome consists of violence, aggression, irritability, restlessness, sometimes euphoria, sometimes intense dysphoria, and associated with severe autonomic hyperactivity. If any first year PGT who has been brainwashed by their teachers in forgetting basic biology, they would term these patients as acute mania. But unfortunately, we know better. Unfortunately, we know that these patients are patients of various brain trauma, various sympathetic or various inflammatory activation that has resulted in this syndrome. And when this syndrome occurs due to no apparent macroscopic cause, this syndrome is termed as mania and hypomania in our psychiatric dictionary. So the phenomenology exists. Neurology has already named it paroxysmal sympathetic hyperactivity syndrome, and we have named it bipolar mania and bipolar hypomania. Without understanding and without seeing the neurology and the neurologist test. This would be a very good example of addressing the invisible elephant in the room by two occupants of the same room. One is seeing the front part, one is seeing the back. There are some various other examples. If anyone who has interest in reading past literatures of psychiatry and its pharmacological research, they would find that around 1940, 1950, there are various papers which have actually published results of clonidine and only clonidine in men. And there, clonidine proves to be a good drug for controlling men. At that time, remember, we didn't have all the pharmacological armamentarium that we had in 1980s or even that we have today. But they used to use clonidine with great effect. Now we don't use because now we have been sold the neurotransmitter hypothesis and we are following it diligently without questioning it, similar to our gospel following nature and axiom following nature. But even if someone is interested today, they can give 300 to 600 microgram of clonidine to patients along with benzodiazepine, and they would find the patient would recover from any supposed mania or hypomania episode. Those who are adventurous and working in intensive unit setup, they can do the same with dexmedetomidine. And that would be known as sympatholytic drug controlling mania. Now, there will be another question posed to the audience. Ask yourself, how many of you have seen ICU people using dexmedetomidine to hyperactive delirium patients? Most of you who have ICU attachments, who have multi-specialty attachment, would have seen dexmedetomidine used in hyperactive delirium. And what is hyperactive? Hyperactive delirium is a state where patient is aggressive, patient is violent, patient cannot really understand the orientation, time, place, and person sometime. And along with that, patient is admitted in a place which is disturbing patient's chronobiology. Except chronobiology part, all the things are exhibited by many patients. So, clonidine and spongianas are still used for the same purpose that we used to use in 1940s and 50s. And we never really pause and think. Because in psychiatry, the first thing that we use is our ability to think critically and our ability to question. In psychiatry training, people are taught to not question. They are taught to believe in every gospel. Then comes various other evidences. Other evidences like longitudinal follow. Any of you who see regular patients would have multiple patients under you. Be you work, whether you work in a teaching institution and you are a second year or third year PG, or whether you have passed your PG many decades ago, all of you have seen patients longitudinally who presented with severe so-called violent episode, agitated episode, which used to be called mania. Then these patients later went into paranoia, went into obsessive symptom, went into severe withdrawal, and ultimately were given psychosis stamp. Then, after a few years, a few more episodes of aggression and violence occur, and to make the honor of Kreplin intact and to uphold the Kreplinian dichotomy, the stamp was changed from bipolar to schizophrenia and finally schizoaffective. That is actually the usual outcome in most of the patients of so-called serious mental. All of them ultimately get stamped as schizoaffective. Some are unfortunate enough to get schizoaffective and obsessive tag or schizo-obsessive with affective. And what is common in all of them? Premature graying of hair. Graying of hair starting from front part of hairline. Wrinkling of, very early wrinkling of skin. Various metabolic syndrome, which were invariably blamed on our psychotropics. Various kind of disease which affect their other organs, cardiac, renal, gastrointestinal. Many of them develop autoimmune diseases and always are blamed that due to taking of our psychotropics, they are ill. Unfortunately, these are the patients that have the same brain disorders that creates this mania and that creates this schizophrenia and things like that. So this is a very short discussion on our love of tag, our love of upholding the axiomatic nature of psychiatry and then our love of tradition. That is actually ultimately destroying our subject's credibility, our subject's name, and creating a bias. People have either schizophrenia bias or have either bipolar bias, and they love to tag the patients with these names without understanding none of the tags matter. What mattered is adequate treatment, and adequate treatment doesn't need this type of tag. With this session this 7 session long session on basics of major psychosis health is in. Psychiatry would have done much better if we have stayed in ages of major psychosis and have not delved into schizophrenia, subtypes of schizophrenia, bipolar, subtypes of bipolar, and ultimately now molecular division of bipolar and schizophrenia. It is like building castle in air, then redecorating the castle, and now giving the castle on rain without having any basis for any of this. Now it is open for questions. I hope you have lots of questions.
Dr. Malay, can you just chip in now and take over?
Yeah, sure. So the questions that come up, actually, there's only one question right now. So the question is from Dr. H.K. Bedi, where Dr. Bedi writes, we many times change diagnosis frequently, fearing that some medical legal issues might crop up. And doctor summarizes as trauma effects. How to deal with this in clinical practice? So I think what Dr. Bedi wants to ask you is that when we are discussing disorders in this format, how do we justify the diagnosis on paper, which would be valid from all perspectives, including medical legal perspective?
Ideal, we should write the symptom and symptom evolution, then write the closest matching DSM and ICD code with a declaration that this is a code from DSM and ICD and it is just a symptomatic description. It is not denoting any disease as per current medical knowledge. That would be a better approach rather than giving just unknown. Yes, ma'am.
Sir, I really agree with you, and this is an issue which is which I agree I'm facing quite a lot. And every time a patient comes, and then you feel this, and then you feel that is also there, and actually there is no typical book patient, and but we are supposed to give a diagnosis. For what we have been taught is that for two doctors to communicate with each other for that reason. And then
Yes.
when we write a diagnosis, then there is a prognosis and a whole plan associated. And when you frequently change it, you yourself start feeling a bit, discomfort yourself.
Unsure and insecure actually.
Yes. So
Because
then,
I have been there myself. I know.
then afterwards, what I do is I write the summary of the symptoms, and below it I write that clinically, because trauma can be psychological. There will be usually I do find a stressor. The trauma may be physical or psychologically. So trauma affects off. That's how I've been proceeding. But I still don't know what I'm doing is right or wrong.
There are various ways you can. One is your way, and I cannot fault you for writing that. I write description. I write that as I say, I write what was the symptom evolution from birth if the history is available, or otherwise from the first contact or from when the first history is available. Then I write that according to DSM or ICD, this would be the closest matching name, but it is not a diagnosis. It is just a language of communication and it is just a symptom description. And in some patients, I actually am able to get some molecular diagnosis or some pathophysiological diagnosis. For example, if I get a history of childhood epilepsy, which needed treatment for few years, then the treatment was stopped, but the patient remained impulsive, angry. Patient was going into various anger outbursts. Patient was into or is into various forms of addiction. Then I write after everything possible channelopathy, possible epileptic channelopathy, which is now off. In this case, I am fairly certain that there is a background pathophysiology of ion channels. But in most patients, we cannot reach in this type of diagnosis. So, clinical description, symptom evolution, and then the closest matching ICD DSM, and with a disclaimer that this is not a disease. That way, I feel that I am not stamping the patient. Otherwise, in my EG days or in my SR days, it was a struggle. OCD with psychosis, with a few episodes of mania, and I was thinking to myself, what is the point of it, and things like that.
Right. We have another question from Dr. Hotiana. As we discussed, there are no differences in the course of this last few talks, that there are no differences pathophysiologically in schizophrenia, bipolar, schizoaffective. Which other groups of disorders are frequently mistaken to be different? What are the which are the big 5 main disorders according to you?
What is phobia? Is anxiety? Is depression? Is OCD? Obsessive compulsive disorder is not there. It is just obsessive compulsive personality trait, which is like some of these patients would develop a particular thought in excess to the others and would develop distress to it, and they would come to us and we would term them OCD. Sometimes these patients would come to us with severe level of anxiety and phobias, we would name them phobic anxiety. Sometimes these patients would come to us with recurrent no mood and we would give them name of recurrent depression. Sometimes these patients would come to us with various concerns which are related to their body and their body proportions, and we would name them somatic delusion, hypochondriacal delusion, or hypochondriasis, or somatic symptoms predominant possibly. And sometimes they would come with various compulsion directing towards body part, various compulsion directing towards various behavior, and you term them Hypomania, this thing, that thing, and things like that. And ultimately, these are actually frequently a single group, a single block. So, what are the now? If you ask me, what are the big 5 main disorders in brain? I would say there are no big 5 main disorders. Brain have a continuum of symptoms. just like, let me ask a simple question. The closest organ that matches with brain in interconnection, number of cells, importance, and size is liver. Liver has 135 billion cells. Brain has about 1 billion plus cells. Liver has similar level of cell-to-cell connection. Liver has similar level of important activity, and liver has similar level of complexity that brain shows. The difference between brain and liver is 1,000 times more plastic than brain. When we talk about liver, we talk liver shows decrease in function, liver shows increase in function, liver shows this hypercholesterolemia, liver shows that hypercholesterolemia, this LDL cholesterol is due to liver, that VLDL cholesterol is due to liver. Do we express diseases of liver that way? We don't. We divide the liver into infective disease, inflammatory disease, or autoimmune disease, storage disease, then degenerative disease, and number 5, a combination of both. And along with that, we add anatomical malformation and neoplasia. But when we come to brain, we try to define each behavior as a disorder. So the problem is in our conceptualization. Our problem is in our perceived brain superiority and our perceived idea. So if we talk about liver in such a, why can't we speak about brain in same? Brain has infective diseases, inflammatory and autoimmune diseases, then developmental and diseases or anatomical defect diseases, degenerative diseases, malignancy, and ultimately a combination of. If you want me to name the main disorders, I would say these are the main. I would never say schizophrenia, I would never say depression, I would never say. Those are psychologists who are trying to find a psyche, their contribution. None of them have any pathophysiological basis. None of them have any biological basis. None of them has any biomedical basis. If you term a patient depression, if you term a patient psychosis, ultimately the treatment doesn't matter. If in acute state, patient is violent, patient is very disturbed, you would start with agent which should calm the brain. Then you would start with agent that would stabilize or rather to halt the degenerative and inflammatory process. And then once the acute phase is over, for chronic phase, you choose a drug which would have effect in increasing the functioning of it. Be it psychosis, be it mania, be it acute anxiety, be it anything acute and anything chronic, you would follow the same. So why should we even bother about these names? You should stop thinking about these names. You should just take them as symptoms. Because ultimately we are doing the same thing.
Okay. One question comes is this. This is from Dr. Divay Mangala. Do making categories help in prognostication?
No. The best example would be when I am excluding Malay Bhai, he is 10 years senior to me. But when you or me were PGTs, we were reading duration of untreated psychosis and how it is prognostically so much. I remember in my PG days, people used to talk about it like it changes the whole thing. Jump cut to 20 years after, duration of untreated psychosis is not even a footnote because it is already been proven that this duration of untreated psychosis has very less or even probably nil impact on prognosis of psychosis. So already duration of untreated psychosis has proven to be a rated. Similarly, all the categories are red herrings. Previously, bipolar, that is, people are coming with a violent episode and inter-episode recovery used to be thought as good prognostics. But later, now we can see that those patients who initially started with acute episode followed by inter-episode recovery ultimately go to not recovery between episode and their prognosis matches with the people who had continuous episode. So rather, these phenomenological categories are not helping us. They are giving us ideas about what a patient presented with. And that is important from a initial clinical point of view, but for prognosis, they hardly matter.
Okay. Another question from Dr. Bedi is with gut-brain connection, how would things change in psychiatry? Any thoughts on that?
Madam, let me introduce you to body of brains. This is first brain. Here we have the largest of brain. Then there is spinal cord, backside, and cerebellum. The second brain. The third brain is in here. The cardiac brain. The intrinsic autonomic cardiac nervous system or cardiac intrinsic autonomic system. It is as complex as the brain. Then let's go to GI system. There is another such. Then let's go to liver. There is another such. Then let's go to skin. Another such. Then let's go to kidney. Another such. Then let's go to lymphatic system, including lymph node and various. There is another way. Then comes the blood vessels, another large way. Then skin, probably the largest brain in the world. So we have a body of brains. So gut-brain axis is just one of the brains communicating with central. Gut-brain axis is not very special. Yes, there is a microbial angle to gut-brain axis, which is not seen in any other brain and CNS aspect except skin. In skin, there is also a huge point. as we are now getting more promotion and more funding material for gut microbes, so gut microbes are in high. When we would get more funding for skin microbes, yeah. But ultimately, microbes are important, probably from a prognostic point of view, probably from a developmental point of view, as microbes and our immune system they co-develop over millions of years. So any immune system abnormality will be reflected in microbial content of our microbiome, and through that, by examining microbiome in skin or stool, we can assess the immune system function in a particular place. Other than that, we have a body of brains, multiple brain. There are multiple connection with central brain, and so discovery of empiric nervous system is not much. We should also start understanding beside brain gut axis, brain heart axis, brain skin axis, brain lungs axis, brain liver axis, brain bone marrow axis, brain lymphatic system axis, and various other brain and body organs.
Okay.
So this is the change.
Okay. So another question by Dr. Usman is, are we going towards ultimate reductionism in near future? Because most of the disorders that we deal with fall into the CSTC loop failure, insular dysfunction, basal ganglia dysfunction, network dysfunction. What are your thoughts?
Reductionism is not the way I would describe. I would say what reductionism actually is a very derogatory term in psychiatry. Probably because most of the psychiatrists are followers of philosophy, and in philosophy, reductionism is looked down upon in Western philosophy. In some Eastern philosophies, like Mania and Sankhya Darshan and Charpak Darshan, actually reductionism is celebrated, but I am not going to. Reductionism means what? In brain, I don't know what would be called reduction. In brain, we are going towards our unitary. We are finally starting understanding that brain is not a unique organ. We are understanding that brain has extension to every body organ. Brain has various dysfunction that is similar to all body organ, and so we are finally classifying brain dysfunction similar to body dysfunction. Autoimmune dysfunction, infective dysfunction, degenerative dysfunction, developmental or anatomical dysfunction, and combination of all dysfunction. It is neither reductionist nor it is very unique. It is just the way biomedicine classifies disease in all other organs. So we are just trying to lose the unnecessary burden that psychology has placed on you. Nothing more.
Okay. Dr. Ankur Singhal asks, why do we prescribe antipsychotics and anti-epileptics in so-called mania or episodic autonomic hyperactivity?
Because antipsychotics are drugs which reduce cellular activity, every cellular activity, be it cell in skin or be it a cell in brain. So by reducing cellular activation, by reducing cellular excitation, it reduces the hyperexcitable state that brain goes into when it is in mania, hypomania, psychosis, or severe autonomic dysfunction. Antiepileptics are drug which reduces cellular excitation as well as cellular conduction, cell-to-cell transmission, electrical transmission, as well as chemical transmission. More electrical transmission than chemical transmission. Antipsychotics affect more chemical transmission than electrical transmission. So, antiepileptic also would reduce the same thing, and they can reduce any hyperactivity of any cell in body. That makes us use antipsychotic and antiepileptic in brain hyperexcitability.
Dr. Divay Mangla asks, how can we explain mixed affective symptoms? Is it hyperactivity, autonomic hyperactivity and underactivity alternating very fast? I mean, how do we
Mixed
look at it?
affective symptom is autonomic hyperactivity, but autonomic hyperactivity is triggering the amygdala circuits more. Amygdala suppression of reward circuit more and basal ganglia more, and affecting the lateral leventula and medial leventula modulation of brain more. And in pure so-called mania, the reward circuit is traditionally activated. That is the difference between mixed and so-called euphoric. But the more you see these patients, you would understand that there are very few patients who stay in pure euphoric state most of the time. The more we spend time with them, the more we observe them, we would find that they would alternate between two different states, because ultimately it is just feedback loop activation versus main loop activation.
Okay. Question by Dr. Jacob. In irritability or anger outbursts in so-called soft bipolar not responding to psychological intervention, which works better? Anti-epileptic mood stabilizers or second generation antipsychotics?
Second generation antipsychotics or first generation antipsychotic or anything that bears the name antipsychotic reduces chemical transmission between cell and reduces cellular activation. Anti-epileptics on the other hand also reduces excitation, but they affect the bioelectrical conduction. So, if the irritability or anger is due to impulsivity more or more due to some electrical disturbances, bioelectrical disturbances, then theoretically anti-epileptic would work better. And if they are due to chemical transmission disturbance more, theoretically psychotics would work better. But unfortunately, we have not reached that level of sophistication in our technology where we can find out which is or whether something is there, something more is there. So at this moment, it is more of a trial and error and scientific guesstimate, where we try to see whether there is hypervigilance or not. If there is hypervigilance, then generally antipsychotics work better. But if there is no hypervigilance and paranoia, then both work the same.
Okay. I had a question in my mind. See, when we are looking at, I mean, this is not related only to today's discussion on autonomic hyperactivity and things like that. But if we consider that hyperactivation or an underactivation as the main base for the various kind of psychiatric illnesses that we are looking at, why is there, number one, a variety of symptoms that are present in different individuals? Number two, why is there a different, not only psychiatric, but let's say neurological symptoms, other system symptoms in variable degrees? So, let's say, to make it very simple, let's say when we talk of hyperactivation, why do all people who have this hyperactivation not have only mania? I mean, why don't all of them have mania?
Exactly.
Why is there a variation? Somebody has anxiety, somebody has a seizure disorder, somebody has tachycardia, somebody has got irritable bowel syndrome, somebody has got a pro-inflammatory activation or autoimmune activation. So what is
Exactly.
that causes this kind of variation in presentation, given that the underlying pathophysiology remains, if we assume that it is hyperactivation or underactivation?
Problem is we are not having a single cause of hyperactivation or single cause of underactivation. If we go into deeper, there are probably at this moment 4 to 5 crore or 40 to 50 million various conditions which could lead to the same hyperactivation or hyperactivation. And along with that, there will be different anatomical connection. For example, let's say I take myself as a index finger. I have myself vulnerability towards developing frontotemporal lobar degeneration because of my family history, where 11 members of my maternal side, my mother and her 11 brothers and sisters have died of frontotemporal dementia. So that means I am carrying the frontotemporal dementia side of genes. Now, that is one part of my inheritance that we now know. But along with that, what other anatomical variation? Let's say my brain has those genes which were there in my mother and her 11 siblings. But along with that, I also have a squint, divergent. This divergent is not there in my maternal side. So this has a separate anatomical pathway in my brain that has created this. Then I have a right to left confusion unique to me, which is not seen in my maternal side of family. So that has been created by various other either molecular mutation or molecular mutation coupled with macroscopic anatomical deviance in my brain, because right to left confusion is seen in a lot of attention deficit people. Then I have also a hugely tall structure, which is unlike India. My height is 6 foot 6 inches. This height is not seen in my maternal side, not seen in my paternal side. So there are many anatomical pathways in my body which is divergent from my parental side. So although I am carrying vulnerability genes of frontotemporal dementia, I have also various forms of anatomical as well as genetic mutation in my body that is giving me a completely different phenotype than my other family members. So I am manifesting some completely other form of brain as well as body hyperexcitation, because frontotemporal dementia is actually a brain and body hyperexcitation syndrome. In my body, it has manifested as childhood onset hypertension. I have hypertension since my 17 years of age. Almost young adult onset diabetes. My diabetes has started at the age of 26. Almost young onset hyperlipidemia, because I have triglyceridemia since 27 years of age. I have hypercholesterolemia since 30 years of age, and various other metabolic problem which actually is not there in my other families. So you see the same hyperexcitability I also get, but due to my own mutations and my own anatomical deviance, my part of disease is being carried by my
Source.
endocrine system and
Source.
my cardiovascular system. So that is how we change.
Okay, so if I say that we need, we would probably be looking at a core genetic dysfunction which causes abnormalities in the hyperactivation, rather activation profile.
Yes.
And then there are these other genes which will kind of modulate the final phenotypic presentation of brain or whatever system gets more, the more vulnerability hits. Is that what you're trying to say?
Yes.
Now the
And
question.
we are
Yeah.
so far
यहीं
behind
रख दे।
technology that at this moment we can't even imagine how vast the variation.
Yeah. So in when we are kind of again, so when we are understanding psychiatric disorders like what we just discussed, a primary core of excitation, inhibition, disequilibrium, let us put it, and then secondary vulnerabilities which will be more specific towards a certain type of phenotypic presentation. We if we understand this kind of framework, and with whatever agents we have, with whatever medication, with whatever pharmacotherapeutic agents we have, or other modalities, or let's say stimulation procedures in terms of ECT or whatever. So are we able to really match the profile of the treatments that we have to this kind of a framework of illnesses that we are talking about? Because it ultimately will boil down to what symptoms an individual presents and how best we are able to match that with the armamentarium that we have at hands. So whether we are looking at a symptom of clusters which is defined by DSM-5 or ICD-11, or we are looking in terms of purely overactivation or underactivation, we are still not, or rather we are quite far off from offering full treatments, full remissions for most illnesses. So this is
Yes.
what my hypothesis is. So in this regard, what do you think? So that is a question which has come up. What will be the holistic treatment of hyperactivation spectrum of disorders beyond pharmacotherapy? So then when we are trying to understand and we are honest with ourselves that we are not there. We are not even
We
partly
are
there.
not.
We are,
But we are not even fractionally there.
but that's some
We
part.
are
So yeah, that's some little part. So we are partly there. We may not be 99.9% part there, but we are there. We probably seem to be on track. And for the rest of what we are struggling to understand or struggling to offer our patients, then there are a lot of things that will, probably be uh, 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 advertised or recommended as treatments. One of them is when you really talk of these multiple brains in the body, one is the pre, pro, and postbiotic kind of treatments. Second one is what else? So, what are your thoughts on that? Apart from so basically for us clinicians, the challenge is how best we are able to fit a particular agent or a particular modality of treatment to the presenting symptoms. Symptoms, by symptoms, I don't mean just limited to what the brain is presenting, but other symptoms as well. So what do you think? What else could be the future of rather not understanding? I mean, of course, we need to understand more, but managing this equilibrium, or rather managing the disequilibrium.
The thing is, I hope with this series, I have been able to show something that is very, very odd. The thing is, we are Neanderthals. We are having crude weapons which are equals to Paleolithic weapons. And what we are fixing is a quantum, which is beyond our technological understanding, our technological progress, and we are just trying to conceptualize that quantum computer as units. That would be the first message of it. First, we should appreciate that we are Neanderthals trying to fix a quantum computer with our Paleolithic. Now, with this, yes, we are behind by light years. But can we do something? Yes, we can do something. If there is immune hyperactivity in any organ, then that is hyperactivation. And all our tools that reduce the hyperactivation would reduce time. So, in case of, let's say, there is myocarditis, there is hepatitis which is non-infective, or there is severe hyperactivity of brain. The basic thing is the system is going towards hyperexcitability, and we need to give either or a combination of antipsychotic and antidepressant. Sorry, anti-epileptic. Now, our understanding of antipsychotic and anti-epileptic changes as we start understanding activation pattern. If anything that reduces electrical activation fast and chemical activation later is a anti-epileptic, then all the calcium channel blockers, all the antiarrhythmic agents also become a form of anti-epileptic agent and activation reducing agent, and vice versa. Similarly, all the chemical activity preventing agent, be it antipsychotic, be it protein kinase inhibitor, be it Janus kinase inhibitor, be it monoclonal antibodies directed towards interleukins or TNF alpha or various other inflammatory mediators, they are actually molecules that helps in reducing chemical activation. So it opens up our armamentarium. It also gives us an understanding how widespread we can use our tools. But unfortunately, this comes with a caveat. None of us have any idea that how much force is required for our Paleolithic tools to repair the computer without breaking it parts. So yes, we have liberty to use various molecules in various situations. But how much do you know about the molecule and how much the brain can tolerate it or the other organs can tolerate it, that we don't. So we should proceed with extreme caution. We should proceed with the fear that we are incurring in something that is beyond our technological comprehension and scientific comprehension at this stage. So, yes, if we think that way, it opens up a huge new horizon. But with it comes a huge responsibility. We are dealing with something that is light years ahead of us. And so we must be cautious and must not go around thinking we can win everything.
Thank you, Bhaskar. Thank you, everyone. This was the last question, and I hope this series that has been taken up, this set of lectures that Bhaskar took for us have kind of uh, been like a morning alarm to all of us that we now need to be wide awake and uh, go about looking at things with fresh eyes and fresh thinking. Uh, Thank you so much, everyone. And with that,
Dr.
yeah,
Malek,
Sir,
there is one question from Dr. Bedi, if you can just take up.
yeah.
it's so
Yes.
nice of you, sir. Thank you, sir. Very kind, sir. Sir, I'm currently facing this patient, sir, young girl, 16 years old, severe depression, and not an athlete or anything. BP is like 93, 64, like, so now I have given her a day of 3 salt capsules. Still BP is that much only. Now I don't know. I'm scared to give the further psychotropics if she goes into hypotension. Now, hearing this, now it seems like a part of hypoactivation only. So, do I need to treat it separately? Do I need to do a medical specialist referral for any
Yes.
cardiovascular problem?
Does she have
Ideal is
hyponatremia?
No, sir, I have not checked for hyponatremia now because she only had like hypotension, and
Yeah.
otherwise there is no other symptom
No, no,
like
hypotension
headache or
is fine, but
confusion.
hypotension is
Only
fine, but
3 capsule. So if I have to go more, only 3 capsules of salt I have given, sir. Nothing more.
that may work only if there is hyponatremia. It will not work otherwise.
Yes. So
For
fast we have,
hypotension, the treatment is not hyper salt capsules. If it is documented
yes.
hyponatremia, then maybe it will work. Maybe her
I thought
basic
maybe excessive. Okay.
no,
Okay, sir.
that might lead to other problems. That might lead to hypernatremia and some other
Okay.
kind of problems.
Sir.
And
Exactly.
90-60 BP is not a bad BP. It is okay, unless she has symptoms.
No, she has no symptoms, but I just thought that if it goes below that, then what? Because we are
If
not
her see, the BP is a range. It is not one fixed figure 120/80.
correct, sir.
So if she is healthy, she is doing all her activity. The only thing
Sure.
that needs is monitor if at all. But for a young girl, this seems to be an okay BP. Now, that apart, for the depression part, you need to decide what you want to do.
Okay. So
But anyway,
should
let
I?
Bhaskar give his
I
opinion.
would say that do a endocrinology and definitely follow Malayabai and do a complete electrolyte booster. Otherwise, giving salt capsule has no value. If the BP is this, Carl has no symptom, then we need to be checking the endocrinology. If the BP is this and the Carl has symptom, then we have to find out whether there is any autoimmune dysfunction or not, and we have to do autoimmune testing by tilt test and other thing. So ultimately, it is actually whatever is there that ultimately would be multisystem. So it is better to involve a competent specialist physician. That person can involve cardiologist if required, or can involve other specialists if
Thank you so much, sir, for giving me the time. Thank you, all of you, sir.
Thank you. So yes, thanks once again, Dr. Bhaskar and everyone for being here and eagerly participating in our discussions, raising new questions, giving us more food for thought. And with that, I hand over the proceedings to Dr. Rajkumar sir. Thank you.
Thank you, Dr. Bhaskar and Dr. Malay. It was a good talk, and we hope to look further a fortnight later back again. Thank you, friends, for being with us, and thank
from
Alchem.
next day onwards, it will be a different topic. Our
Yeah.
psychosis and mania and the overall this part has ended.
Yeah. Thank you all, and thank you, Knowledge Partners Alchem CNS, for this session on Brain on Wednesdays. Good night to all of you.
Good night.
Good night.